Good morning, everyone. It's nice to be with you today on a very important topic around the idea of dementia, living with dementia, understanding dementia, thinking a little bit about how do we still think about quality of life and associate that word with dementia, because I think that gets lost. And so my name is Ali Shivji. I'm one of the principals at Optima Living, and really excited to be here today. And Dr. Adrian Wagg is our guest. Adrian's the AHS Chair for Healthy Aging at the University of Alberta, also an active clinician and very engaged in kind of seniors' health and a well-known figure in that regard. So Adrian, always nice to have you here. I wanted to talk a little bit about this idea of dementia, and wanted to maybe start by thinking a little bit about this idea of how do we understand, particularly as loved ones and families of those who are living with dementia, what are some of the warning signs up front that someone has dementia versus something else? You know, there's a lot of times, and jokingly people will say, "Oh, I'm getting dementia. I forgot this. Like an Alzheimer's moment or whatever." And I think that, joking aside, there are some things that are clearly telltale signs that something is happening, and other times, maybe as simple as a clinical UTI, which we've had a lot of time. We've seen a lot of our residents who maybe just have some sort of urinary tract infection, some sort of other thing that's made them a little bit delusional at that moment, but there's an external factor that's a short-term measure. So if you were thinking about this in terms of helping a family member identify, what are some of the warning signs that actually someone does have dementia?
So you're right. There's a general level of misunderstanding about dementia, and is Alzheimer's disease dementia? Is it different? And obviously dementia is an umbrella term for a number of underlying diseases which lead to a gradual deterioration in what we call cognitive function. So not only memory, but managing, planning, thinking for ourselves. Alzheimer's disease is the most common form, but there are many other causes, and when you get to that stage, a doctor can, on basis of probability, make a diagnosis. So what should you look for? Well, the first thing, of course, that affects, annoyingly, more or less everyone after the age of 50 is exactly what you said. I've just walked into the kitchen. Why did I come here? Hang on a minute, go out again, and it comes back. Yeah. That short-term memory, short-term recall becomes a little less good in association with aging. There are other things that are very well preserved, even in people living with dementia, such as what we call autobiographical memory, which is my story, my upbringing, my longer term memory of myself and my life. But what we tend to look for is not just the short term memory thing, but where, compared to other older people, your overall cognitive function is not as good. And typically things that we call executive function are affected. Can't plan ahead. I used to know how to make a recipe without thinking about it. I now can't get things in the right order, or might miss things out. Or when I'm driving, I can no longer manage all of the tasks that I need to get from A to B without either getting lost or you're getting quite stressed and disturbed. That ability to manage several things at once gets affected. Undoubtedly, as we get older, it takes a little bit longer to learn things, we take a little bit longer to respond, and that would seem to be normal aging. Our vocabulary and our articulation skills, our eloquence, gets better, in fact, until the 6th decade, and it is preserved until very late life. So memory changes, but it's not all downhill by any means. People will often say, well, granddad or grandma's getting a bit forgetful, but when does that become, is this dementia? And it's then where it has an impact on daily life. It's not just forgetting where your glasses are and then picking them up later. It may be forgetting where your glasses are and accusing people of stealing them, or when things go missing, abnormal responses to gaps in memory. Not being able to handle simple financial transactions, or handling money in stores, for instance, getting confused about the value of coins or money, perhaps being more vulnerable when there are well-known telephone scams being taken in much more easily. Those are the kind of warning signs that we would counsel. But also then failing to manage. And that's often difficult when people are in long-term relationships where one person may cover for the other. There may be someone who's cognitively frail that's being supported by a cognitively able person, and when that person either becomes unwell or absent, then things go very quickly to hell in a handcart where all of that safety net's removed.
Yes.
So being aware of memory changes and what might be more than that might be expected. But of course there are memory tests you can do, and short memory tests that are online or available in doctors' offices, so you can monitor your cognitive function and monitor it over time. We do have, in addition to dementia, this thing called mild cognitive impairment, which might be a deficiency in one area of memory or cognitive function that is relatively stable over time. It comes at a slightly greater risk of developing a dementia over time, but just needs monitoring because there's no active treatment for it. I think we talked in one of our previous discussions around healthy brain aging and the things you can do to mitigate risk, so we shouldn't probably go into all of those things again, but there are those warning signs around not managing quite so well, maybe not paying attention to your own hygiene or clothes or laundry, reduced social activities, reduction in eating habits or reduction in ability to cook for oneself, things like that that start to raise alarm bells for family members or other care providers of an older person.
If you, how can people support their parents or their spouse in daily living after they've had a diagnosis? So let's say, for instance, you've now got a diagnosis, but now how do you still live an active life? It's not the end of the world because of the fact that one has it.
No, you're right. It isn't the end of the world. Certainly from either mild or moderate disease progression, you should treat people probably no differently. There's a great temptation is there to start doing things for an individual. And we know that making people redundant is very bad for them. Losing a sense of purpose is very bad. So encouraging as much independence as possible to preserve quality of life is really important within the capabilities of that individual. And we often counsel family members to make sure that people are kept busy and they don't vegetate in front of the television and are left alone, because it's easier to do things for them than to get them to do things for themselves. Eventually, people will need prompting or reminding, and fairly regularly so, but that's a later stage.
Well, and it's interesting you say that, because I think, particularly in Optima's kind of brain health model and some of the memory care work that we do, active engagement is actually a very important part of life for our residents, and be it the way that they participate in activities, the way that they may, help cook, maybe they're help part of, like that whole aspect of giving them purpose is a very important and underlying part of what we do.
Everyone has that horror image, don't they, of a residential home where there are high chairs around the corner of a very large room and everybody's sat and that's it.
Yeah,
and that's entirely the wrong model. And I think that active engagement models such as yours are clearly the way ahead to keep people's quality of life as best as it can be, that they're engaged not only with the care providers as members of their team and their family, but also their family coming in from the outside. And this idea of an integrated residential unit with its local community. So those links aren't lost either. And in fact, those links should be encouraged.
Yeah. When it's actually interesting when you say that. I was going to ask you a question, then I realized that one of the things that I think about often, and I try to get people to think about, is that I ask them to think a little bit, how would they picture, that worst case, dementia home that they may be scared about, and people have talked about people sitting in chairs watching TV, people, sleeping or whatever, but everyone's in this room, and then I often ask them to close their eyes and say, okay, well, I'd like you to picture a room that is full of feather boas and laughing and singing and burnt toast only because someone was accidentally, toasted for longer, or that there's engagement in life. And that's our vision for how we think about, individuals living with a dementia, because it's, again, dementia doesn't have to change everything about how people view you. It's just like if I'm living with a cut arm or an ulcer or whatever, I'm living with that. It doesn't mean that I am that.
No, absolutely. Family caregivers will often say that the response of friends is to withdraw. It's almost like they say it's almost like the individual has died and there's a grieving process and a withdrawal, and maintaining social connection for the individual but also for the family care providers, care partners, is extremely important. Not only so there's support for the care provider, care partner, but also for the individual, to maintain as much connectedness as possible for as long as possible.
Well, and I was actually, you read my mind in terms of the next question I want to ask you, which is, if I'm a family member, what can I do to support my loved one that has dementia? And how can I think about that maybe in a different way?
Well, I think you said very nicely, the person living with dementia, it's not the end of the world. It's how living with another chronic disease. You should treat them exactly the same for as much as you possibly can, and resist that desire to do things to remove sense of purpose, to really try and make sure that life is as full and as active as it possibly can be. Clearly, at some point, the disease will manifest such that might not be possible, but you then learn to work with that. And the Alzheimer's Society of Alberta and Northwest Territories have great programs of care partner support, which can really improve the health literacy around this. I think there's a great, not only an under-recognition, an under-diagnosis, but also an under-care, if you like, and not an awareness of how it might affect people, what to expect and when, and how to deal with that.
Yeah, I think that's a really interesting point, because, one thing is an underdiagnosis, but I think the bigger challenge is that understanding, the lack of understanding of how much care and support is required. And that it doesn't mean they have to change the way that you interact with that person, but there may be some back-end supports you need to beefen up, and that there are places that you can go to get help.
Absolutely. And I think that the things that most people are concerned about is financial vulnerability, and there are safeguards that can be taken to ensure that if the person living with dementia is making unwise decisions, that those can be safeguarded. And then that falls back on us all for our relatives to make sure that we have those advanced care planning documents, that we not only just have a will, but have an enduring power of attorney and a personal directive, such that people who, with our best interests at heart, can take over those things as required, but also safeguard the person living with dementia from scamming or making unwise decisions. One hears continually dreadful stories in the press about older people who are taken advantage of by unscrupulous individuals. But you can, for instance, remove the tap and system with debit cards. You can reduce the amount that can be withdrawn at any one point. You can ensure that checks of a certain value can't be cashed. So there are lots of safeguards that can be put in place to make it possible for an older person to live the best life they possibly can, but not do themselves harm.
Yeah, how do we enable people to live their best life? And sometimes there's simple tweaks, for sure. You talked a little bit about the Alzheimer's Society. Are there other organizations or places that people can go to get support that are worth mentioning?
Certainly in the Edmonton area, Alzheimer's Society would be the obvious one, but there are memory support groups at various senior centres. There is a care partners support program that runs out of the Glenrose Rehabilitation Hospital. So it's really looking for available resources in your area, and the Seniors Association of Greater Edmonton has a wonderful online resource which is a compilation of available services, and the City of Edmonton itself has just reviewed available community resources for seniors and is updating its websites. And I suspect that for many people in Sherwood Park and the surrounding towns, those areas are covered as well.
Yeah, and I think likewise for most of the large cities, even in Richmond and BC and others, I think there is a huge amount of directory of services, and that you're not alone.
No.
When dealing with this.
Well, that's the thing, isn't it? Everyone feels that no one else is going through this, and actually there is a lot of people going exactly through the same thing, and getting that mutual support and hints and tips about how to manage certain situations is of immense benefit.
Yeah. Is there we talked a little bit about what happens, and how we should treat people, etc. But is there something about what we should anticipate if my loved one has been diagnosed? Like, is there as much as we don't want to treat them differently, are there things that we should anticipate so that we're not surprised and maybe broadsided by them?
Well, again, I think getting an idea of what might happen as the disease progresses is important. Thinking about whether there are any medical treatments that might be suitable, albeit that the treatments for Alzheimer's disease in particular are not that great, and there has been medical trial failure after failure. We have no new treatments. So we're doing the things to reduce cardiovascular and cerebrovascular risk factors to slow down progression where we can. We are using the medications if we feel that they might retard things a little, but otherwise it's trying to work with quality of life, preserve independence as much as possible, and make sure that care partners have adequate support and the individual themselves has the best quality of life they can.
Let's talk about the topic of care partners. Oftentimes we see in our communities that, and now having been in this industry for a long time, that oftentimes people worry about the person that's not doing well, the patient, if you will, although I would consider this more of the resident or others, but yet it's actually the caregiver that I'm more worried about. Because they tend to be the person who actually burdens shoulders and sometimes protects the world from seeing what's actually happening. But they also then take on a lot of that burden themselves. And the plight of the caregiver becomes something that is actually really important. And we see this manifesting itself in multiple different ways. I had a conversation just this morning with a family, where we were talking about, dad taking care of mom and everything's fine. And mom should be totally fine, but, dad handles it all. And right away for me, that's almost always a flag to say, hold on, do we really understand how much dad is actually doing? And at what point does it become burdensome for the caregiver? So if we talked about the caregiver, maybe the first thing is if there's a caregiver of someone who has dementia who's watching this right now, what are the things that we need to remind them are not normal, that they shouldn't do by themselves?
Well, I think people will have very different capabilities, but I think what tends to happen is that the care partners, care providers tend to then cut themselves off. They tend to have no time for themselves. So availing oneself of available respite services is clearly important. So you can get at least a bit of time to do things for yourself when the person living with dementia can no longer be safely left for prolonged periods of time. So you're right, that idea of caregiver, care partner stress and burden is very important, and it leads to a lot of ill health, particularly mental ill health. A study that we did really looking at care partners for people with incontinence showed that up to a third of them were clinically depressed, and those kind of figures are writ large through care partners of people living with dementia. That's only the psychological burden. Then there's the physical burden of the tasks that you never imagined yourself doing in late life, and simply holding the household together. So where you have the resources and the wherewithal to get domestic help, to avail yourself of available respite services, to give yourself a bit of time to do stuff, becomes really important.
Yeah, no, I think that is so important because, and that is one of the things that we help people understand as well, is that, even at the Astor Gardens kind of memory care department that we've been really thinking about is how do we make sure the program is structured in a way that people understand that they have to almost in some ways step away and look at themselves as individuals in terms of what their individual care needs are. and then bring it back in terms of what support you do for your loved one. But at some point in time, you also have to look out for yourself.
Yes.
And realize that there may be a better place for your loved one than just under your care at home. And that's a really hard thing for people to understand. But it gets into this idea of like, when is it the right time to consider that that we should look for memory care options for a loved one? That, you know what, that they shouldn't necessarily be at home any longer.
We find that it's often, some family physicians will say, does this person need a different level of care? And it's not a medical decision. It really is a family care partner decision, where, you know, is the burden of caring for this individual in their own home too great? Is it impractical to provide it safely? All of those kind of things need to be taken into account. Together as a family, are we unable to provide the best care for that individual, so that, and they are actually then not benefiting from the care that's provided? Could a different structure provide a better quality of life, I think, for that individual? And largely it's around the nursing home transition that's hugely burdensome. Of course, then there's that problem that you rightly said, the letting go. People who have cared for the person living with dementia, they've cut themselves off from all of their previous social contacts and friends. They're now fairly socially isolated, but they are almost dependent on the person living with dementia. They decide that they need to go to a congregate living facility and then still can't let go. And then it takes that much longer to reconnect and regain their previous life. And may never do so, at a great psychological cost to themselves. So preserving the quality of life of the care partner is, in a way, as important as the person living with dementia.
Well, and I can understand that in some cases, and we've often, I remember, you know, working with a family who, you know, we had, you know, the husband had dementia. They eventually moved into one of our communities, and the wife just felt so guilty. Right? She felt so guilty to go out with her friends, to continue to go golfing, to do other things, because she thought, well, my husband's there and I'm not. And we just spent a lot of time with her, just helping her understand that it's okay to separate that, because, you know, if you've, again, put him in the right community, in the right environment, then he's actually going to be having a wonderful time himself. And how would he feel if he knew that you were not, you know,
what you describe is far from unusual, that sense of guilt. To the detriment of the health of the individual, yes.
So, you know, what is the difference, you know, in the systems or the environments that you've seen? How does one tell what a good versus a bad place is for their loved one when they're thinking about memory care, you know, memory living, etc.? Like, would you say that there are certain things that they should look for to understand, because, you know, not all things are equal?
No, I think the primary thing is one of fit. Given what the care partner knows about the individual, their likes and dislikes, how they function, you know, can the facility cater for those? What's its ethos in terms of engagement? How is what is the environment like? I think certainly we know that you know, natural light, the outside environment, the sense of community may be really important to some people and less so to others. So the fit is clearly important. The standard of care, so the organisation, the culture and ethos of any particular home. It would be great to say that there was an independent quality inspectorate for all of these kind of things that could guide people. And in some jurisdictions that exists, but often it's word of mouth and reputation. So you know, there is no single quality mark, and the quality standards that we do have in Alberta often don't consider those things that family caregivers would think about. It's as much around safety and health and safety and environmental controls as much as what care partners would consider as the quality of care or existence, or the recreational facilities available, or the diversions, if you like. Yeah,
no, I think that definitely makes a lot of sense. do you think, though, that when we're thinking through those different aspects of that fit, are there areas that sometimes people don't associate with fit, but that they should?
How do you mean?
Well, so when I think about people coming on tours, or when we walk through people coming to visit our memory care units or our memory care neighborhoods, we talk a lot about saying, well, make sure that you look at everything from the level of interactions between the staff and the residents. Look for small things about how do people eat together, or are they separate? Are people engaged in a way that they're meaningfully doing things as opposed to just alone by themselves? Yep. Do you look and see that there's a lot of TVs that are just on, or is there active engagement that's going on? We ask people to look at just hygiene in general and observe it to see other things that they feel like are not.
Yes, I mean, people often talk about the sniff test, don't they? And that's good.
Yeah.
So is it obviously environmental things? How's it structured? Is there some kind of group activities? Is there an actively engaged residents committee or family care partner committee who are involved in feeding back around things in the home? Can any tour also include discussions with other family members or other residents that can respond and talk about their lives in any facility? All of those things, I think, are additions. It's a bit like, I guess, test driving a car. It'd be nice if you could have a short break in the facility to really sample what daily life might be like. And I know some facilities that do offer that.
Yeah, no, absolutely. And I think it's important that fit is as much intentional by words and other stuff, but also sensorial, right? How do you feel? How do you think about those things can be really important as well. When we're thinking a little bit about this idea of saying, okay, I've decided that my loved one, be it my parent, my spouse, should move into a community. How do I start to prepare them for the move? How do I start to make sure that
it will be difficult always, depending on the degree of disease. I think it becomes difficult to prepare when there is limited retention of information, where there is often repeated questioning, and it's often a question of emotionally preparing the care partner as much as the person living with dementia. Clearly, deciding what familiar objects need to accompany the individual is important, such as a semblance of familiarity where people can recognize and gain a bit of quality from their environment and things they enjoy and like to have around them. But when push comes to shove, it's always going to be difficult on the day.
Yeah. And have you found that there's a set of conversations that one can have, that there are, there's different areas that may just help smoothen that process?
Again, there is no hard and fast rule, and I haven't found anything in particular to recommend. Often the care partner finds it more traumatic than the individual.
Yeah, no, that is also true. When we think about this a lot, we think about it in our communities around saying, one, there's aspect of familiar objects. There are aspects of familiar photos and other aspects, but there are also, we spend time and we have an entire kind of questionnaire that we spend time with families on. And, one of the things that we've done at Astor Gardens is you have the ability to pick the door. Mm-hmm. And we've got effectively, I think it's like 200 different images that can wrap your door so that the door looks you can pick the door that your loved one had, because they can then recognize their room in an easier way. Or so there's little subtle things that we've tried to do about, interacting with this idea of choice and with individualization in parts of the design that allow people to be able to feel as comfortable as possible. And I think that's a really important part here, which is like, how do we create that comfort and that ability to welcome you home, which has been a philosophy of ours, ever since our inception. But that has been very important for us, is to do that. And then the other part too is to socialize, like bring them in, socialize over a period of time, come for maybe an hour and then come for a couple hours every couple of days and kind of get into this. I think I liken this actually to the way that introducing my daughter to a new school. And I said, okay, on the first week, you're going to bring her in for an hour a day.
Yes.
You're going to stay in the building. You're going to be around, and you're going to, it's the socialization of that is.
I think the social integration of the new resident is really important, and
Yes.
I've anecdotally had good reports and bad reports. The feeling that there's already an established number of cliques which aren't going to accept any newcomer, versus almost a welcoming committee, a new residents welcoming committee of the established residents, and trying to integrate people rapidly. But clearly it's a huge transition and takes time as much as anything else, and I would expect that 4 to 6 months before people start to feel settled into a routine and a structure and start to integrate with other residents.
When we think a little bit about this idea of, let's say, for instance, someone is moved in, or we found the right environment for someone to be in. How do we move forward from an engagement perspective? How do we make sure that when we come to visit or when we interact with someone that is living with a dementia, that we have the most meaningful engagement with them? We often have times where, I remember one family member came to us and said, well, I don't know what to do when I come to visit Dad. I feel like I'm twiddling my thumbs, or I'm reminding him of that old time, and yet you've told me that we got to think about this bridge and the fact that they've crossed it. So how do we prepare ourselves and then engage with our loved one when we spend time with them?
I would say making the interaction as meaningful as possible, and that might not be sitting in the corner chatting about days gone by and reminding individuals. It may actually be taking them out. It may be going out for a coffee, or doing things, or going for a stroll, or going to a mall and experiencing the outside world as much as the inside world. It may be simply accompanying the person living with dementia in some of their daily activities that they undertake whilst in the facility, or interacting with multiple people in the social context in which the person living with dementia now exists. Reminding somebody of what day it is 20 times isn't going to gain you anything, and people are going to forget. So it's making that interaction as meaningful as possible and as conversational as possible.
Is there, when we talk about conversations, are there conversation topics that are better than others?
Don't know. I don't think there's any merit in saying that your auntie's died again 19 times does anyone any good. Of course, people don't remember. So again, there's no hard and fast rule. There are rules about communication, around simple language, around using gesture and touch as much as verbal communication, which are really important. But there are no hard and fast rules around subject matter. People often say, well, should I remind them that they've just got something wrong? But if it upsets them, don't do it.
Yeah. We very much adhere to this idea of the fact that ultimately we want to start with the 5 senses of the resident, and really think about the sensorial experience that people have, as well as the way that we can cater to those to make them as comfortable as possible. Oftentimes, there may be something as simple as the way that a sound is coming. When we designed Astor Gardens, we thought about every single detail, including the size of the air dampers for the HVAC unit, to make sure that they're not too loud and they're not too direct on people. Visually looking at color palettes to make sure that people don't feel like there's dark and light spots and the color contrasts that are there. So those sorts of things we found are very, very important, and thinking through those and being very clear about them, but then also thinking about meaningful engagement pieces and spending time with family members when they come to engage them with what your loved one is doing.
And you will know about and have adopted many of those age-friendly environmental modifications. You talked about colour and texture and materials, and certainly the ideas of wandering paths and circuits, and the use of external environmental features, all of which have got good evidence behind them in terms of reducing the level of agitation and responsive behaviours. And that's all extremely laudable. And again, family members should look for that kind of thing when they are thinking about entering a facility.
No, that's very, very helpful. I'm just looking to see if there's any other questions from today's audience. I think, there is one about this idea of how do I maintain a healthy relationship with my parent? Living in a community where I don't necessarily visit them often. So when I come, they may not recognize me. When they, how do I think through that and understand?
I think that's exceedingly difficult for individuals because, of course, you are attaching all of your past history and emotional connection with the person living with dementia who is your dad but doesn't behave or recognize you the same. And I think often we advise people to adopt a friendly conversational interaction. But of course, we do find people living with dementia who appear to be less than charitable, let's put it that way. And that whole weight of emotional baggage is put behind that in the recipient, even if it's meaningless for the person living with dementia. And it's part of the education about how dementia affects people in its later stages and coping with trying to be as objective as you can be rather than really wrapped up in the emotions of it, because then the family care partner or family member suffers.
Yeah, no, I think that's very right. And I think we think a lot about this idea of saying also manage your expectations and planning ahead of time to understand what does success look like from an engagement is important, because it may not be what it was in the past, but it doesn't mean that it can't be very meaningful in the future.
And of course, people will have good days and bad days.
Yes.
And it does vary incredibly. And you may decide that if it's a bad day, to cut short that visit and try again later. I think being persistent can be irritating to some, and then a bad experience is shared.
Yeah, no, we've covered a lot today. I mean, we talked everything from this idea of warning signs and understanding that ultimately we all will have at periods of time lapses in memory or short term, but ultimately it's when there's a particularly a loss of executive functioning, when it becomes hard to manage several things, when ultimately they're abnormal responses to gaps in memory or abnormal behaviors that just aren't the regular ones, or probably when it starts to say, okay, well, what are signs that things are going a little bit wrong, or that we should at least start to look at them. When people are failing to manage in multiple areas, or sometimes when a caregiver is taking over for the other in many, many ways, and at some point in time you realize. I've also found that sometimes people are smart. Sometimes people have a dementia, but they're very smart, so they have a regular sequence of things that if they use these answers every time, no one catches on. And I think being very attentive to those things is a very
important. Call that a social
part.
front. People are very good at bridging and covering.
Social fronts are sometimes very difficult because of the stuff that's unsaid. That there are tests out there that people can use, and we talked a little bit about that in terms of understanding, that sometimes that's an important thing to look at, and that also there's a distinction between dementia and a mild cognitive impairment. And they both have their own ways of, not necessarily treatment, but of how to handle them, and it's important to understand that there's a difference. It seems like every conversation we have, we come back to this idea of healthy aging, right? And healthy brain aging is something that's also very important and fundamental to us at Optima, and to a lot of the work we've been doing in the Optima Brain Health model around how do we create a meaningful brain aging environment, and actually a healthy aging environment that includes brain health, be it the food you eat, be it the activity you have, be it the exposure you have to different activities and engagements. All those are very, very important. We talked a little bit about the fact that, look, what happens if a loved one is diagnosed with a dementia? And I think the first point, and I think a very appropriate point you said, is don't treat them any different. People don't need to be treated differently because they've been diagnosed. Just like if someone's been diagnosed with a heart condition or has had cancer. I mean, maybe cancer is a bad one because people have to sometimes pity. But I think if you look at the way that in general people are now starting to handle chronic diseases or non-communicable diseases, it's the same sort of thing. Don't treat people differently. But remember that everyone needs a good quality of life. And just like someone who has a heart condition needs a good exercise, by the same token, someone that maybe has some form of cognitive impairment, well, they need to be still engaged and stimulated and have a good quality of life. They may need to be prompted and reminded, but that's okay. We talked a little bit about this idea of, the fact that people tend to withdraw. and that, they tend to almost feel like someone's passed away when they get a dementia. And that's not the case, and it shouldn't be. But that it's okay to ask for help. And that if you're feeling that there's something that's beyond you or that is just awkward or different, you're not alone. There are many people who are dealing with this. And we talked about the Alzheimer's Society. We talked about multiple organizations that have different services and different things that people can look at. And I know that regular communities have multiple kind of directories of services. I know Strathcona County has that, the City of Edmonton, the City of Richmond, etc. Financial vulnerability. We talked a lot about that. And I think financial vulnerability is interesting because it happens often. I think even this morning I had two calls on my cell phone of these random CRA, your SIN number, other things. The fraud out there today is extensive, and it's already difficult as it is. But there is safeguards that we can put in place, and there are certain things, dealing with your personal directives and dealing with your enduring power of attorneys, helping to safeguard your loved one up front. It's important to get some of that advanced care planning documents done, and we'll be doing some future webinars on this whole idea of advanced care planning because it's so important. But then little things like reducing or getting rid of the tap and pay function on your credit on the debit cards of your loved ones, putting limits on their accounts so that the amount that a check can be cashed, so they can still live meaningful lives. But we do it in a way that still has those safeguards in place. We talked about places of support, obviously, and the different support groups that are there. We talked about the fact that sometimes there may be medical treatments or there's some to reduce risk factors in different areas. It's important to understand those things. We talked about the plight of the caregiver, the care partner, that, oftentimes we're actually more scared about the care partner than we are about the loved one. So the available respite services, the understanding that it's okay to be able to go out and get services and that there are many things available to allow you to get help. We talked a little bit about this idea of the fact that there are ultimately what's the right time to look for a community to live in. And this isn't a medical decision, it's a family decision, and it's based upon the burden that may be happening on the family. What is the best quality of life that someone can lead? If you truly are looking out for someone's best interests, where is the best place that they can have the quality of life that they deserve? And oftentimes it's hard within a home environment to do that because you need different supports. But letting go is hard. And we talked about this idea of the fact that the people sometimes can't let go, they can't bring themselves to doing that, and ultimately preserving the quality of life of everyone, the person in question and or the people around them is very important. We talked about criteria. There's so many things here as I'm going through, summarizing our conversation, because we're talking about this idea of the fit and how it becomes an ethos of engagement, and what are those things that are very important. If you come to an Optimum facility, if you came to Astor Gardens, you'd see a lot of natural light. You'd see an engaging level of meals that people are cooking together, activities that people are doing together, levels of hygiene, cleanliness, or even the way in which we would deliver meds or be kind of person-centered. All of those things are just very, very important for us to think about. That sniff test is a very important one. Discussions with other residents and going through to understand that. How do you prepare for the move? Well, it's going to be difficult no matter what. So, coming up with and finding familiar objects, social engagement, socializing, and taking some time to do that will be important. And then how do we make meaningful engagements on a regular basis with every part of people's lives, creating good conversation topics, giving family members good environment, good things, both education as well as the skill sets and the tools to be able to come and visit their loved one and engage with them in a meaningful way, which is part of what we do on a daily basis. I think I tried to cover everything. That was a long summary, but there was a lot there. Anything I missed, you think, on that topic? Or
I don't think so. I think the main message is, if family members are concerned about a loved one, is to seek advice from a family physician who can make an appropriate referral if they're not sure. And we're rolling out the increased ability of primary care to do these assessments and make these diagnoses. So at least you can be fully informed. You can start to put in the advanced care planning that might be needed and think about the future. Often we wait until there's a crisis, and then there's a crisis response.
Yeah. One topic we didn't talk about is made. And medically assisted dying is an interesting topic that started to gain a little bit of traction before the whole COVID thing happened. Then it's kind of died down a little bit. But where are your thoughts on that topic, both from the perspective of maybe how it affects dementia and how people should think about that, but are there other points and considerations that you think are worth bringing up for family members?
Well, so I think in Alberta we have probably the best provincial system for medical assistance in dying. The Act, of course, as far as dementia goes, doesn't allow people to make advance requests, and that's probably going to be challenged. I think that there have been ongoing requests throughout the coronavirus outbreak, and people need to have informed decisions around the reasons for that. And I think I would be a great proponent of preservation of autonomy in this area. And I, in fact, do independent assessments. So you see people with all sorts of experiences, all sorts of underlying diagnoses, and all sorts of concerns and fears about why they request medical assistance in dying. Dementia, largely because of the nature of the Act, isn't one. Now, that is the case in some European countries, so the Netherlands and Belgium, that you are allowed to make advance directives for lack of capacity. Here you have to have capacity when you make the decision, but also on the day of delivery of medical assistance in dying. So we'll see if that does change. There's also a challenge around the criterion of that death is reasonably foreseeable, and that's an appeal that's been launched from a Supreme Court ruling in Quebec around younger, very disabled individuals who aren't dying and don't have a limited life expectancy, and how they're dealt with should they feel that they want to request medical assistance in dying.
It's an interesting topic, and that one I'm sure is going to have multiple effects based upon what happens legislatively.
Yes, and I think again in terms of health inequity and equality of access, there's a bias towards the well-informed, well-educated, socio-economically advantaged, whereas the maybe people that don't have as much health literacy have an inequitable access to this kind of thing that we've got to try and change it. And it's true for many disease entities in later life that affect seniors and maybe people who are less advantaged than others. So to improve the health literacy of all is clearly something to do.
Yeah, agreed. Well, thanks for your time. It's always a pleasure, and I know we've covered a lot, so we'll unpack that as we go, but always a pleasure.